the last chapter we talked about psychological disorders. This is kind of a complementary chapter on treatment. Healing actions, healing words, healing pills even, but let's just kind of talk about that. One common way to treat psychological problems is psychotherapy. And there's a lot of assumptions that people have or beliefs about what psychotherapy is. Some people believe that the therapist should be an expert, others an equal. Some believe the therapist should be passive, others believe the therapist should be real active. Some believe that psychotherapy should focus on what's going on in the present problems. Others feel that they should address how the past is influencing the present. Some just focus on what you're conscious of. Others focus on what they believe are unconscious forces. Some on behaviors. Some more just on your changing your thoughts and not your behaviors. And we're going to talk now about some of the different types. One of the earlier prominent types was psychoanalysis. Talk therapy. And when Freud originally came up with it, you'd meet actually 5 days a week. And now it's much more common to meet with a psychotherapist or even an analyst once or twice a week. But the idea was that people had these hidden conflicts, these kind of repressed impulses, and if you were able to bring them to consciousness, that insight into the cause of those symptoms would kind of make the psychological problems go away. This was the theory behind it. This was considered to be, an insight-oriented therapy. Again, the first use of what we call the talking therapy developed by Sigmund Freud. As we mentioned, he's looking to identify these unconscious motivations, and the techniques he's using are called free association, dream analysis, resistance, and transference. Free association was really just having the person kind of lie on the couch and say whatever comes to their mind in a sort of uncensored way, and Freud believed that would lead to these unconscious motives. As with dream analysis, he felt dreams had, our kind of unconscious motives in symbolic form. If there seemed to be resistance in therapy where you didn't want to talk about something, oftentimes that was interpreted as something important that was being kind of repressed or pushed away. And then transference, this idea that you sometimes end up transferring feelings and thoughts and stuff onto the therapist. Usually you transfer thoughts and feelings from previous important relationships, and the idea is that maybe that'll help you to identify what some of these unconscious kind of motivations or problems are. Nowadays, people don't do as much of that. As I mentioned, the psychoanalytic. Now you see a psychologist, if they're in the psychodynamic kind of once a week, they're not going to emphasize as much the kind of classic Freudian sexual and aggressive drives. And the techniques are going to be different. They're going to use interpretation. They're going to try to interpret, your behaviors and what they think is going on. They're still going to look at resistance and transference and stuff, but it's actually, much different than it would have been, 50 years ago or longer. Another type of insight-oriented therapy was Carl Rogers' client-centered therapy. I think you remember we talked about that a few times. One in I think the motivations chapter. But remember, Rogers believed that there was a certain amount of incongruence in, or if there was a certain amount of incongruence between the real self and this kind of ideal self, that you were constantly kind of anxious and repressing and trying to avoid these, this kind of discrepancy. And if you remember back to his theory, you sometimes would get these unrealistic conditions of worth, probably inadvertently from your parents, that you were worthwhile, if you were lovable, if you were a certain way, and it results in these kind of distortions of self-concept. In client-centered therapy, the therapist was just very, kind of displayed this unconditional positive regard, and they felt like if you did that you would move towards self-acceptance and psychological health or self-actualization. So in this, client-centered therapy technique, all Rogers would do, and he was a master at this, is he would reflect what you were saying kind of back to you, in slightly different words, be very empathic, and treat you with unconditional positive regard, regardless of what you said. And the idea is if he created these conditions for you, you would naturally accept yourself and can self-correct and move towards psychological health. These insight-oriented therapies like the client-centered and psychodynamic are difficult to evaluate, and what is actually helping. And there's limits to who kind of benefits from psychotherapy. They often say it's already people who are kind of very verbal and psychologically healthy. They seem to benefit the most, and some people who aren't as verbal or have more kind of severe psychopathology aren't going to benefit much from this kind of focusing on insight. Behavior therapy, we talked about that numerous times before, in learning and other things, but there's a number of therapies based on these learning principles. They're designed to change your observable behaviors. They focus on the antecedents of certain behaviors, the behaviors and the consequences, and they try to, these are called the ABCs, and they try to modify consequences to elicit behaviors that you want, and so on and so forth. There's some techniques based on classical conditioning, so if you're afraid of something, or even like obsessive compulsive disorder, where there's an exposure part of it where you're exposed to the thing you're afraid of, whether it be dirt or water or spiders. And this exposure can be imagined, it could be virtual reality, it can be in vivo, right there. You could have a spider that's right next to you. But it's coupled with systematic desensitization where you learn to relax. And so you are exposed to a feared stimulus, first a mild one, and then they get more and more intense. And when you're exposed, you work on relaxing so that before you move on to the next stimulus that makes you fearful, you're fully relaxed. And then you move up this hierarchy, and then eventually you can come in contact with whatever you're afraid of, and be relaxed and get over that fear. Cognitive therapy has become one of the dominant forms of psychotherapy, and it focuses on thoughts rather than feelings or behaviors. Behaviors are important, feelings are important, but the cognitive therapist feels that thoughts kind of drive the feelings. And it's a real active approach where they're looking for cognitive distortions in the way you think, and has a real strong psychoeducational component. They're teaching you to monitor your own thoughts and to kind of modify those. A very popular book years ago, and there's a number of others that are related to this kind of cognitive therapy is Feeling Good, the New Mood Therapy. But here's a couple of examples. It says, some people have these kind of dichotomous thinking, black or white, these mental filters. They only see certain things, oftentimes they're negative. They mind read, they think, they're jumping to conclusions about what other people are thinking. This kind of catastrophic exaggeration, like, boy, if something goes bad, it's going to be horrible, everything's going to fall apart. Have these kind of control blinks where they're not in control. And they teach you to identify and kind of combat these in this particular therapy. So in Aaron Beck's cognitive therapy, he would teach you about this cognitive restructuring, these distortions. Then you would keep a daily record of your thoughts that cause anxiety, and then you would stop and identify, okay, I'm feeling anxious. What was going through my head? Then you would label the distortion if you can, and then identify a rational response to it. I'm jumping to conclusions. That person probably wasn't mean to me. They were probably having a bad day for some other reason. And then you again, then kind of reassess your anxiety. And people can get really good at identifying these distortions combating them in a real good way and reducing that depression and anxiety. Biomedical therapies are very, very common. Prozac is one of the very, for a while, it's one of the more popular antidepressant medications. It got a lot of kind of popular information, a lot of popular press, some good, some bad, about its effect on people's behaviors. But the biomedical therapies are huge business. They're very popular. They're here to stay. Now, for something like schizophrenia, drugs are almost essential. These antipsychotics are almost essential. They really help to remove these positive symptoms of hallucinations and delusions. Unfortunately, they have some side effects like tardive dyskinesia that makes you have kind of tics and facial movements. Some of the more newer atypical antipsychotics are getting a little bit better at these symptoms, a little bit reducing some of the side effects. But again, the antipsychotics are almost essential for somebody who's got schizophrenia to kind of get control of those symptoms. The antidepressants, very controversial. Some people swear by them. Some people feel it's all a hoax or placebo. It started out really early with these tricyclic antidepressants and these MAOI inhibitors or MAOI inhibitors. More recently, they've developed drugs that target serotonin, the selective serotonin reuptake inhibitors like Prozac, Zoloft, Paxil. And then there's some that target both serotonin and norepinephrine, like Serozonin and Effexor, and some others. There's some natural St. John's worts natural herbs that are supposed to have some of these serotonin enhancing qualities. Lithium is one that's real popular for bipolar and real effective with that. The anxiety drugs, the problem with them is the benzodiazepines, Valium and Xanax and stuff, they're good, they help for a short period of time, but they can be habit-forming or addictive. Actually, the antidepressants are probably a better choice for treating some of these anxiety disorders. Depression and anxiety both seem to respond some to the antidepressant medications. Electroconvulsive therapy is used usually in depression. The medication therapy is ineffective. It fell out of favor. I think it was abused probably decades ago. And then, if anyone's seen the movie One Flew Over the Cuckoo's Nest, it kind of highlighted that abuse in a Oscar-winning film. The bottom line is, though, it's regaining in popularity. It's sort of the last treatment of choice for somebody who has depression, and it can be effective. It does result in some short-term memory loss, but normally you get that back. And again, they use this for in people who nothing else is working. There's a transcranial magnetic stimulation. This is a very new technique. I've only seen a few articles and presentations on it, but they give you these microsecond bursts of high-intensity magnetism. It's supposed to be almost as effective, or as effective, as electroconvulsive therapy. It is a bit painful from what I understand, but it's probably better than inducing a seizure. And I don't think I mentioned that, but that's what electroconvulsive therapy does. They put electrodes on your scalp, make sure that you put something in your mouth to make sure you don't bite your tongue, and they induce a seizure. And it's a seizure that has these kind of antidepressant, the same qualities as an antidepressant. So, transmagnetic stimulation may be hurt a bit, but it's better than, I think, inducing a seizure, if it's truly that effective. And I think there's a lot of different ways that you can be treated. We typically associate psychotherapy, individual therapy, one-on-one, but there are group therapies for people who have similar struggles, family therapies, sometimes whole families are dysfunctional, then a whole form a whole variety of self-help therapies, support groups, bibliotherapies, just books, self-help books, and they can all be effective. And depending on what the problem is, you sometimes need the entire family there, or it's better to have a group of people struggling with the same thing. I think that is it. Thank you. Bye.